Bismillahirrahmanirrahim. Hi everyone. This is the third video regarding abdominal pain. In this video and the coming ones, we are actually going to talk about when CT scan or imaging is non-specific, it didn't give you the exact diagnosis, and the patient is still having abdominal pain. What to do next? What are the causes that might be associated with normal imaging? And some of these are common, some of these are less common. And actually, this is probably the main reason I have this series. So let's start. Okay, so when your patient is having pain, especially if it's a recurrent pain, and imaging, including CT scan, is not very specific or it didn't really give you the diagnosis, I suggest that you have a framework in your mind to go over the other possibilities based on history and exam. So for me, I think generally I have six big categories for these potential diagnoses and possibilities. Number one, most of the time, honestly, it's still gonna be in the abdomen. The pathology is still most likely be within the GI tract, but it's just not showing up in the imaging. So we'll go over that. We'll go over these possibilities. And then, okay, maybe the pain, the source of the pain is not inside the abdomen, maybe it's outside. And especially in the hospital setting, for me as a hospitalist, it's important to rule out important diagnoses above the diaphragm, including the heart and the lung pathologies. So that's always in my mind when someone is coming in with upper abdominal pain. And then I always keep in mind the nerves that supply the abdominal wall or abdominal cavity. Sometimes these might present early without gross findings in imaging. So keep those in mind. We'll talk about that. And then, of course, medications, side effects. Honestly, almost always any medication can be associated with GI symptoms, but some of them are a little bit more common than the others, and these are the ones that you need to keep in mind. But definitely a good medication history is important, especially trying to correlate the onset of abdominal pain with the onset of taking the specific medication suspected to cause the pain. And then less common but also relatively important causes are metabolic causes, endocrine causes, or some of them has some genetic possibilities. So these are also very important not to miss, especially if the patient is coming in with recurrent abdominal pain without a clear cause. And in many situations, the imaging in these patients might not reveal the diagnosis to you. And then, of course, if you do all the appropriate investigations based on history and exam and basic testing, and the patient is still having abdominal pain and doesn't have risk factors, it could be like functional abdominal pain or psychogenic abdominal pain, and we'll talk about that as well. So these are the six possibilities, generally, like just a general frame to think about when your patient is coming with acute abdomen or abdominal pain, and initial imaging at least, is not revealing. So the first category, and probably the most common causes of abdominal pain when imaging is not conclusive, is that the pathology is most likely still lies within inside the abdomen. Some of these possibilities include early pathology like early appendicitis, diverticulitis, gastroenteritis that actually is still not very clearly shown in imaging, or imaging might suggest like maybe possible inflammatory markers or signs in the report. And we already talked about the case in the first video with the patient who came with upper abdominal pain, and the imaging was not impressive, and he ended up having acute cholecystitis. That's because common things are common. Sometimes these common pathologies they might present with the common presentation, but sometimes they just present with less common presentation, but they're still common. So you have to think about the common things first. So keep that in mind. Even if the image is not impressive, think about common pathologies first, and then think about what else you need to do, whether you repeat the image down the road, or you closely observe the patient, or you do another test that might give you more clue to the diagnosis. Early gynecological disease, sometimes this could be challenging, especially in females, for example, pelvic inflammatory disease (PID), which is largely a clinical diagnosis. It's based on symptoms and signs such as vaginal discharge and motion tenderness in pelvic exam. And also endometriosis, which is also based on clinical suspicion. And then pelvic ultrasound might give you some idea, but some patient might need laparoscopic exam to make the diagnosis. So pelvic disease in general, this is one area that ultrasound might be more helpful than CT scan, so keep that in mind. But in a lot of these pathologies, the diagnosis is really largely based on clinical suspicion and some basic testing. But sometimes it really might be challenging to make that definitive diagnosis. Severe esophagitis from any underlying cause, and including reflux esophagitis. Again, this is also largely based on clinical diagnosis, but some patient might need an endoscopy, upper endoscopy, or EGD. Esophageal motility disorders also might need some special tests like motility testing, just like GERD or reflux, when some patient might need pH or acidity testing. So yeah, this happens in few cases, but again, it's just largely based on history and a physical exam and maybe EGD or upper endoscopy. Acute gastritis, peptic ulcer disease, kind of very similar. Infiltrative gastric disease like sarcoidosis, amyloidosis, lymphoma, these are less common, but most of the time they might need upper endoscopy and biopsies to make the diagnosis. Eosinophilic GI disorders like eosinophilic esophagitis and eosinophilic colitis. These are becoming more and more recognized nowadays. Some clues to this diagnosis include presence of eosinophilia in the CBC that's not explained by other common disorders like asthma or allergies. Low albumin, part of that because of the loss of protein in the feces. Iron deficiency, high inflammatory markers like high ESR. So if you see these in patients with GI symptoms and imaging is not very impressive, think about eosinophilic disorders, and then you might need further testing, including upper endoscopy as well and biopsies. Gastroparesis, relatively common. Patient might present with abdominal pain, but they might not have abdominal pain. They might have other GI symptoms like nausea, vomiting, bloating, or early satiety. Not necessarily diabetic patients. Of course, diabetes is a common cause of gastroparesis, but almost 40% or more of cases are idiopathic, and you might not know the exact underlying cause, but you still have to pursue and seek other secondary causes to try to treat that underlying cause. And in the hospital setting, you might make that diagnosis clinically. You might order some motility testing, but the best is really to do it when the patient is more stable, because in the hospital they usually the patient already received a lot of motility medications, so that might affect the result of the gastric emptying study that you order for your patient. So in these disorders, again, upper endoscopy might be needed, some biopsies, some special testing might be needed to reach the diagnosis, but keep those in mind. These are probably the most common causes for abdominal pain when imaging is not very impressive. Another group of GI issues that might cause some abdominal pain or discomfort that might not clearly show on imaging include food allergies. These are relatively common, maybe more in young or pediatric population. It could be IgE mediated, which is kind of classic, maybe more severe, but there's also the non-IgE mediated, maybe a little bit more in adults. You look for, in addition to the GI symptoms, look for skin manifestations, symptoms and signs of atopy or allergies or rashes. Some of them might have some angioedema, respiratory symptoms, this kind of things. Symptoms that suggest allergies in general. And really the key here is track the kind of a food diary for the patient and try to link any association between the symptoms, the onset of symptoms, and any type of food that could be associated with food allergies. There's a lot of them, including cow's milk, eggs, bean nuts, wheat, fish, shellfish, bananas. A lot of food can be known to be associated with food allergies. But sometimes you might need to do a little bit more testing, like getting some serology, including IgE level, even skin prick testing, or sometimes just food challenges. Try to introduce the food and see what happens, and then stop or like isolate the particular food from diet, and then see what happens. So food allergies are relatively common, but again, history is really key here to try to track it down. Lactose intolerance, also relatively common cause of abdominal bloating symptoms, kind of vague GI symptoms in general. Lactase deficiency is probably the most common one, but you can get other disaccharidases deficiencies like sucrase deficiency or maltase deficiency. Sometimes could be just a primary disorder. You see that more in Black and Native Americans, but also it could be secondary to any GI pathology, including the common one, gastroenteritis. After some episode of gastroenteritis, patient might develop symptoms similar to lactose intolerance for some time. That sometimes can be variable, a few days, weeks, or even a little bit more than that. So keep that in mind. Diagnosis is again clinical, but you can do like dietary trial. Um, Stop taking any lactose-containing food and see what happens with the symptoms. You need to wait a little bit for like 3 to 4 weeks before you recognize the improvement. Testing is questionable, but if needed, because the diagnosis is not clear, you might need to do hydrogen press testing, and in a rare situation, you might need an endoscopy, upper endoscopy, EGD, and take some samples for lactase activity assay. Small intestinal bacterial overgrowth or SIBO. Also, something to think about. It's quite interesting. I think probably a little bit overlooked maybe. Risk factors for that include generally like stasis. Just think of any disorder that can slow the motility or the movement inside the small bowel or the intestine, including dysmotility disorders, of course, diabetic neuropathy is common one, Parkinson's disease, scleroderma, any cause of the diffuse immune system like IgA deficiency, achlorhydria, decreased acidity in the stomach from any cause, including use of PPI, which is very common, cystic fibrosis, some anatomical changes in the intestine, like after GI surgery or presence of multiple diverticuli. This is where bacteria can hide and grow and proliferate. So diagnosis, again, clinically, you need to suspect it, think about risk factors, and if suspected, maybe you need to do the breast testing to kind of make the diagnosis. In rare situations, you might need upper endoscopy and duodenal aspirate culture for that. But most of the time, the diagnosis is made clinically by the absence of presence of risk factors, and you can do like a treatment trial and see what happens with symptoms. Rifaximin is a kind of antibiotic of choice, but also tetracycline, neomycin, augmentin, and erythromycin, other medication that you can try to kill the bacteria, and hopefully that should solve the problem. A similar entity, a little bit less recognized, is intestinal methanogenic overgrowth, or EMO. It's similar to SIBO, but it's just it's not bacteria. It's actually another living organisms. It's archaea. So these secrete methane, and methane slows gut motility, right? So patient might have some symptoms because of the presence of a lot of archaea in the intestine. Constipation is a prominent symptom in most of these patients, but they can have any other GI symptoms, including abdominal bloating and discomfort. Risk factors is very similar to SIBO, relatively common in patients, or it could coexist with a patient with IBS, irritable bowel syndrome, with the constipation predominant type, chronic intestinal pseudo obstruction, H. pylori, use of PPI, protein pump inhibitors as well. And diagnosis is kind of similar as well. You just need to check the methane levels in the breast testing. Treatment is also similar to SIBO, just with antibiotics. Classically, use of rifaximin and neomycin might be advised. Try that and then see if symptoms persist or not. The list continues. Occult GI malignancy, For example, neuroendocrine tumors. We're going to talk about that in another video in this series. Also, something to think about. Sometimes the imaging might not show it because it's just too small. And patient with cirrhosis and they're coming with ascites, of course, abdominal distension can cause abdominal pain, abdominal distension from any cause. But in this patient, think of ascites and spontaneous bacterial peritonitis. And almost any patient admitted with acute issue who has cirrhosis and ascites, you need to rule out SBP because they might have decompensation from SBP. So keep that in mind. Have a low threshold to do diagnostic percentesis in this patient. Travel history will give you some clues. This is a little bit less common here in the United States, but definitely important in endemic areas or patient who has travel history. This got a little bit complicated. TB, malaria, typhoid fever, abdominal pain here is kind of classic. Dengue fever, tuberculosis, of course. So any patient with travel history or coming from an area endemic of these tropical diseases, keep those in mind as well if you're really not sure about the cause of the acute abdominal pain. Another big category is vascular pathologies. So sometimes with infarction, you can see the infarction in CT scan, or there's like a big inflammation, obvious inflammation from ischemic inflammation. You can see that also. So some situations you can still see the pathology in the CT scan, but sometimes ischemia might cause a lot of pain, but the CT scan might not be very showing. Again, for example, we had a patient, young patient coming in with acute abdominal pain, right flank pain, whom the CT scan showed a right renal infarct. So it was a clue that is like arterial pathology, and later a patient was found to have a spontaneous renal artery dissection, and this known to happen after a strenuous exercise. It was sexual activity in our case report. So keep that in mind. Sometimes vascular pathology, if you just order ordinary CT scan and there is no clear infarction, the patient might still have a lot of pain, but the imaging might not be too revealing. So I'm just going to give really quick examples of such pathologies. They're not really very common. Some of them are in certain areas. So arterial compression syndrome, for example, the big three arteries of the abdomen, celiac artery, superior mesenteric artery, inferior mesenteric artery, can be compressed by any pathology from outside or from inside. But virtually any artery inside the abdomen, if it has a compression or a pathology from inside, a blockage from any cause, they can give you a lot of abdominal pain, right? Ischemic pain, which is known to be painful. So just quick examples, not very common, but it might happen. You might see it: compression of the celiac artery by the median arcuate ligament, which is a fibrous band that connects the diaphragmatic crura. It's called the median arcuate ligament syndrome. So you might see that in the CT scan. You might just see the fibrous band of the diaphragmatic crura really compressing the celiac artery, causing some GI symptoms and abdominal pain. Not very common, but it can happen. A little bit more common, especially in certain areas, certain tribes and ethnicities, like in African American, sickle cell disease. Keep that in mind whenever you have a patient with undiagnosed sickle cell, if they have hemolysis, and especially if they're from African American descent. But also can happen with Hispanic Americans and people of the Mediterranean origin. Most of the sickle cell disease I have seen coming in with vaso-occlusive crisis, they're already diagnosed with sickle cell disease, so the diagnosis is available. But especially some traits, the diagnosis might not actually be made initially. So I think it's always important to keep that in mind in the appropriate clinical setting. Another big group is systemic vasculitis. Again, not very common, but it's always useful to keep in mind in patients with unexplained abdominal pain. There are really many, and they have distinct features. Basically, they're divided based on the size of the arteries usually involved, but there is a lot of overlapping between these syndromes. For example, antiphospholipid antibody syndrome, not very rare. You probably have seen a case or two. Um, think about that in patient with both venous and arterial thrombosis, especially if these happen in an uncommon site. And of course, including the GI or the viscera. They can come in with features of mesenteric ischemia. They might show up as splenic infarction or basically infarction of any other arteries. So antiphospholipid antibody syndrome, with or without rheumatological disease like SLE, keep that in mind. Poroarthritis nodosa, also not very common. You might see it more with patients above 50. Sometimes in young patients as well. It can happen in any age. 25% has abdominal pain. Some of them might have fever. Sometimes even like fever of unknown origin. Patient might have some weight loss. Relatively common, both fever and weight loss. And then if you order a CTA, you might have some features that suggest a diagnosis. Sometimes you might need biopsy of the involved organs to make the diagnosis, in addition to the rheumatological workup and basic testing for rheumatological workup. Eosinophilic granulomatosis with polyangiitis, EBGA, or it used to be called Sherg-Strauss syndrome. GI symptoms can happen, and think about that in patients with GI symptoms and asthma and or allergic rhinitis. Again, fever and weight loss also might happen. So think about that in a patient with fever of unknown origin, and if they have like GI symptoms and eosinophilia. NH1 line purpura, not very common with adults. You probably will see it more in the pediatric rotations, but it still can happen. Patient might have painless purpura, probably the most common manifestation, almost 90 to 100% of patients, followed by abdominal pain and GI symptoms, almost in half of these cases. And then patient might have some arthritis, joint pains, or arthralgias without inflammation, and then fewer patients also might have renal disease. So if you see these combinations, think of NH1 line purpura. Behçet disease, more common in the Middle Eastern men and Asian women. They might have GI symptoms as well. Think of this in patients with recurrent oral and or genital ulcers, eye pain or redness or uveitis, skin rash or other skin lesions, and joint manifestations as well. Takayasu arthritis may be more common in young Asian women. Primarily affect the aorta and its branches, so it's one of the large arteries, vasculitis, but patient might also present with intestinal ischemia. So really these, again, less common, not very common, a little bit rare, but you have to think about them in patients with undiagnosed abdominal symptoms or abdominal pain, especially if they have multi-organ involvement, is other organs involved outside of the abdomen, especially if they have recurrence of their symptoms, and there's really no clear diagnosis to be made. Think about vasculitis. The last one I want to talk about is abdominal migraine. Just because it's really considered kind of a neurovascular pathology or disease, but honestly, it's part of the differential diagnosis in patient with recurrent abdominal pain when you don't really have any other diagnosis, almost diagnosis of fixed occlusion. It happens more common in children and young adults as part of the disorders of gut-brain interaction, DGBI. It's not uncommon, you might see it, but again, you have to think about other more common pathologies before you call it abdominal migraine. Some clues include these patients might have dull midline recurrent abdominal pain. It can last up to 3 days, similar to the duration of the classic migraine. Other associated GI symptoms should be included. Classically, the diagnostic criteria should include 2 out of these 4 symptoms: nausea, vomiting, anorexia, and pallor, which is kind of interesting. Pallor, during the episode might give you a clue to the presence of abdominal migraine. It can be severe, and usually, not always, but sometimes patient might have some family history of migraine that could be a useful clue. And it usually responds to the migraine drugs during the acute episode, and also if you want to use preventive medications to prevent future episodes if you think this is what's going on with your patient. So consider medications you use for migraine like topiramate, propranolol, and cyproheptadine. So these are some examples of causes of abdominal pain when imaging is not very clear or forward. Next video, I will talk about very briefly about some of the causes, relatively common, that you might see, and the underlying pathology is actually outside of the abdomen. See you in the next video. Bye bye.